Welcome to Pediatric Case Review. Today's lecture covers bronchopulmonary sequestration in a comprehensive, board-style format. We will work through 14 carefully designed cases covering the fundamental definition and pathophysiology, the two distinct morphological types, clinical presentations, prenatal and postnatal imaging, surgical management, and the most serious complications. Let us get started. Case 1. Pathophysiology. A newborn patient is incidentally noted to have a congenital lung mass. Advanced imaging confirms that the mass has no connection to the normal tracheobronchial tree. The question is, which of the following best defines this type of congenital lung lesion? Option A, a cystic lung mass with pulmonary arterial supply and communication to the airways. Option B, an overdistended lung lobe with air trapping but intact bronchial connections. Option C, a mass of non-functioning pulmonary tissue with no tracheobronchial communication, receiving blood supply from the systemic circulation. Option D, a fluid-filled mediastinal cyst arising from the foregut. Take a moment to think about the defining features of this condition before we move to the answer. The correct answer is option C, bronchopulmonary sequestration. This condition is defined by three core features. First, it is a mass of non-functioning pulmonary tissue that contributes nothing to gas exchange. Second, it lacks any normal communication with the tracheobronchial tree, so air cannot enter or leave through normal airways. Third, and most importantly, it receives its arterial blood supply from an anomalous systemic artery rather than from the pulmonary circulation. This systemic arterial supply is the hallmark diagnostic finding and distinguishes bronchopulmonary sequestration from all other congenital lung malformations. Case 2. Arterial supply. A 2-month-old infant is undergoing diagnostic evaluation for a congenital lung lesion and is being prepared for surgical planning. The surgical team needs to identify the arterial supply before proceeding. The question is, from which circulation does the aberrant arterial supply of a bronchopulmonary sequestration originate? Option A, the pulmonary circulation arising from a branch of the main pulmonary artery. Option B, the systemic circulation, typically arising from the descending thoracic or abdominal aorta. Option C, the coronary circulation as a branch of the left coronary artery. Option D, the bronchial circulation as an enlarged bronchial artery. Think carefully about what makes bronchopulmonary sequestration unique before choosing your answer. The correct answer is option B, the systemic circulation, typically originating directly from the descending thoracic or abdominal aorta. This is the single most defining diagnostic feature of all sequestrations, regardless of type. Because this vessel arises from the systemic circulation, it delivers blood at high systemic pressures rather than the lower pressures of the normal pulmonary circulation. Clinically, large lesions can cause significant hemodynamic effects from the volume load they receive. Surgically, identifying and securely ligating this high-pressure vessel before any lung resection is the most important step in the entire operation, because accidental division without ligation can result in massive, life-threatening hemorrhage. Case 3. Morphological types. During intraoperative evaluation of a neonate, the surgical team finds that the lung mass is enclosed within its own distinct visceral pleura and is completely anatomically separate from the adjacent normal lung lobes. The question is, based on these intraoperative findings, which type of bronchopulmonary sequestration does this represent? Option A, intralobar sequestration, because it is found within the chest cavity. Option B, extralobar sequestration, because it has its own separate pleural envelope and is distinct from the adjacent lung. Option C, a hybrid lesion combining features of both sequestration and congenital pulmonary airway malformation. Option D, congenital lobar emphysema, because it is a distinct structure. Focus on the critical anatomical detail about the pleural covering as you choose your answer. The correct answer is option B, extralobar sequestration. The presence of its own distinct visceral pleura, completely separating it from the normal adjacent lung, is the defining anatomical feature of extralobar sequestration. By contrast, intralobar sequestration sits within a normal lung lobe and shares that lobe's visceral pleura with no separate pleural boundary. This anatomical difference has an important clinical consequence. Because intralobar sequestration lacks a separate pleural envelope, bacteria from adjacent normal airways can reach the sequestered tissue through collateral ventilation pathways known as the pores of Kohn, making recurrent infection the hallmark presentation of intralobar sequestration. Extralobar sequestration, protected by its own complete pleural covering, rarely becomes infected. Case 4. Venous drainage. A 5-year-old child with a confirmed diagnosis of intralobar sequestration is undergoing preoperative anatomical mapping. The surgical team needs to understand not just the arterial supply, but also how venous blood drains from the lesion. The question is, into which venous system does intralobar sequestration typically drain? Option A, the systemic venous system, draining into the azygous vein or the inferior vena cava. Option B, the hepatic portal system, draining through the diaphragm into the portal vein. Option C, the pulmonary veins, draining into the left atrium. Option D, directly into the right atrium through an anomalous vein. Think about what a left-to-left shunt means hemodynamically before you choose. The correct answer is option C, the pulmonary veins, draining into the left atrium. This creates a left-to-left physiological shunt. Systemic arterial blood enters the sequestration from the aorta and returns to the left heart via the pulmonary veins, bypassing the pulmonary capillary bed entirely. Extralobar sequestration behaves differently. It drains into the systemic venous system, typically the azygous or hemiazygous vein or the vena cava, returning blood to the right atrium. This creates a left-to-right shunt where systemic arterial blood ultimately ends up in the right heart and pulmonary circulation. In large extralobar lesions, this shunting can become significant enough to produce high-output congestive heart failure. Case 5. Clinical presentation. A 7-year-old boy presents with his third episode of pneumonia this year. Importantly, all 3 infections have been consistently localized to the left lower lobe on imaging, with no infections in other lobes or on the right side. The question is, what is the most likely underlying diagnosis explaining this pattern of recurrent, same-location pneumonia? Option A, cystic fibrosis causing left-sided predominance. Option B, intralobar sequestration of the left lower lobe. Option C, a persistent foreign body lodged in the left lower lobe bronchus. Option D, primary ciliary dyskinesia with a left-sided predilection. The specific anatomical localization of every single episode is the most important clue here. The correct answer is option B, intralobar sequestration. Intralobar sequestration represents approximately 75% of all sequestrations, and its classic fingerprint is recurrent pneumonias that always occur in the same anatomical location, typically one of the lower lobes, most often the left. The mechanism is that bacteria from adjacent normal lung tissue gain access through collateral ventilation channels called the pores of Kohn. Because the sequestered tissue cannot clear infection through normal mucociliary mechanisms, each bacterial seeding episode leads to another pneumonia in the identical spot. Any child presenting with recurrent pneumonias in the same lobe should have bronchopulmonary sequestration at the top of the differential, and a computed tomography angiogram should be obtained to confirm the diagnosis before surgical referral. Case 6. Age of presentation. The medical team is analyzing onset data for different types of lung anomalies and noting that extralobar sequestrations behave very differently from intralobar types, particularly in terms of when they are typically discovered. The question is, at what age are extralobar sequestrations most commonly diagnosed? Option A, prenatally or in the neonatal period, within the first 6 months of life. Option B, in early school age, between 5 and 8 years old, during evaluation for respiratory symptoms. Option C, in adolescence, following a first episode of hemoptysis. Option D, in adulthood, as an incidental finding on imaging for an unrelated problem. Think about what features of extralobar sequestration drive its early detection. The correct answer is option A, prenatally or in the neonatal period. The majority of extralobar sequestrations, over 60%, are diagnosed within the first 6 months of life, and many are detected before birth on routine prenatal ultrasound. Extralobar sequestrations are rarely infected because their complete pleural envelope prevents bacterial seeding from adjacent airways. They come to attention either through prenatal imaging or because of respiratory distress in the neonate from mass effect. They are also strongly associated with other congenital anomalies, particularly congenital diaphragmatic hernia, and the workup for these co-anomalies often leads to the discovery of the sequestration. Case 7. Clinical associations. A neonate in the neonatal intensive care unit has recently been diagnosed with an extralobar sequestration. The medical team initiates a full workup for associated congenital malformations. The question is, which congenital anomaly is most commonly associated with extralobar sequestration? Option A, tracheoesophageal fistula with esophageal atresia. Option B, congenital diaphragmatic hernia. Option C, tetralogy of Fallot. Option D, Hirschsprung disease. Think about which anomaly shares the same embryological developmental territory with extralobar sequestration. The correct answer is option B, congenital diaphragmatic hernia. Up to 60% of patients with extralobar sequestration have associated congenital anomalies, and congenital diaphragmatic hernia is by far the most common, often presenting as a left-sided defect. Both conditions involve abnormal formation of structures in the posterior thoracic and diaphragmatic region during early embryogenesis. The extralobar sequestration is frequently found adjacent to or within the hernia sac, so it can be missed if the team focuses only on repairing the diaphragm. Other associations include congenital heart defects, foregut duplications, and vertebral anomalies. In sharp contrast, intralobar sequestration is rarely associated with other congenital anomalies, occurring in less than 15% of cases. Case 8. Prenatal diagnosis. A routine prenatal ultrasound at 20 weeks of gestation reveals an echogenic, homogeneous mass in the fetal left lower chest. Color Doppler imaging demonstrates a distinct feeding vessel arising directly from the descending aorta. The question is, based on these prenatal findings, what is the most likely diagnosis? Option A, congenital pulmonary airway malformation, type 3, based on the echogenic solid appearance. Option B, extralobar sequestration, based on the echogenic mass with a systemic arterial feeder from the aorta. Option C, congenital lobar emphysema, based on the left lower chest location. Option D, a bronchogenic cyst, based on the homogeneous appearance. Pay careful attention to the Doppler finding, as it is the most diagnostically decisive piece of information in this case. The correct answer is option B, extralobar sequestration. On prenatal ultrasound, bronchopulmonary sequestration appears as a well-defined, solid, homogeneous echogenic mass. On grayscale ultrasound alone, this appearance can be virtually identical to a microcystic congenital pulmonary airway malformation. The critical differentiating step is Doppler examination, demonstrating an anomalous systemic artery arising from the aorta and feeding the mass is pathognomonic for sequestration, because congenital pulmonary airway malformation receives its blood from the normal pulmonary artery, not the aorta. This is why Doppler interrogation is mandatory for every echogenic fetal lung mass, as the presence or absence of the aortic feeder changes the diagnosis completely. Case 9. Diagnostic imaging. A 6-year-old child is suspected of having intralobar sequestration after multiple localized pneumonias. The surgeon has requested definitive preoperative vascular mapping before planning the resection. The question is, which imaging modality is considered the gold standard for preoperative vascular mapping in bronchopulmonary sequestration? Option A, plain chest X-ray with fluoroscopy. Option B, magnetic resonance imaging of the chest without contrast. Option C, computed tomography angiography with contrast. Option D, conventional catheter-based angiography. Think about which modality provides the most complete three-dimensional picture of both the vascular anatomy and the surrounding lung tissue. The correct answer is option C, computed tomography angiography with contrast, the gold standard for preoperative vascular mapping in bronchopulmonary sequestration. It is highly sensitive and specific for demonstrating the anomalous systemic arterial supply originating from the aorta. Beyond identifying the feeding artery, it provides three-dimensional reconstruction of the venous drainage pattern and the adjacent lung parenchyma. Knowing the precise number, origin, and course of all feeding vessels before entering the operating room is essential, because multiple feeding arteries are present in approximately 15% of cases, and any unidentified vessel represents a serious hemorrhage risk during resection. Case 10. Complications. A neonate with a known large extralobar sequestration presents with tachypnea, tachycardia, and hepatomegaly. Echocardiography shows a structurally normal heart with no congenital cardiac defect. The question is, what is the most likely underlying mechanism explaining this neonate's cardiovascular and respiratory compromise? Option A, tension pneumothorax from rupture of the sequestration. Option B, high output congestive heart failure secondary to large left to right shunting through the sequestration. Option C, pulmonary hypertension from hypoxic vasoconstriction in the compressed adjacent lung. Option D, septic shock from an infected sequestration. Think about the venous drainage pattern of extralobar sequestration and what happens hemodynamically when that shunt is very large. The correct answer is option B, high output congestive heart failure from massive left to right shunting. A large extralobar sequestration receives a massive volume of blood directly from the aorta at systemic pressure. That blood drains into the systemic venous system and returns to the right atrium, creating a significant left to right shunt. The right heart is therefore pumping a far greater volume than normal, leading to high output cardiac failure. In a neonate, this manifests as tachycardia, tachypnea from pulmonary congestion, and hepatomegaly from venous congestion. The structurally normal echocardiogram confirms this is a hemodynamic consequence of the extracardiac shunt, not a primary cardiac defect. Case 11. Examination findings. An 8-year-old child with known left lower lobe intralobar sequestration is currently febrile and experiencing a superimposed pulmonary infection within the sequestered tissue. The question is, which set of physical examination findings is most consistent with this infected intralobar sequestration? Option A. Hyperresonance to percussion and diminished breath sounds bilaterally. Option B. Normal percussion note with diffuse bilateral expiratory wheeze. Option C. Dullness to percussion and decreased breath sounds with focal crackles over the left lower lobe. Option D. Tracheal deviation to the right with absent breath sounds on the left. Think about the physical signs of focal consolidation within a single lobe. The correct answer is option C. Dullness to percussion and decreased breath sounds with focal crackles over the left lower lobe. An infected intralobar sequestration presents clinically identically to focal lobar pneumonia because inflammatory consolidation fills the sequestered tissue with fluid and pus. When tissue is consolidated, air is replaced by denser fluid, producing a dull percussion note and decreased breath sounds. Focal crackles arise from inflammatory exudate in the small airways over the affected area. The key teaching point is that focal pneumonia signs recurring in exactly the same location always deserve investigation for an underlying structural lesion. Case 12. Treatment and surgery. A pediatric surgeon is performing a standard surgical resection of an intralobar sequestration and is now approaching the most hazardous phase of the operation. The question is, what is the most dangerous step during surgical resection of a bronchopulmonary sequestration and why? Option A. Inflating the ipsilateral lung after resection due to the risk of air leak from the staple line. Option B. Identifying and ligating the anomalous systemic feeding artery because accidental division without ligation can cause fatal hemorrhage. Option C. Dividing the pleural adhesions from prior infections because of the risk of entering the pericardium. Option D. Inserting the chest drain at the end of the procedure due to the risk of intercostal vessel injury. Think about what happens if the feeding vessel is not controlled before it is divided. The correct answer is option B. Identifying and ligating the anomalous systemic feeding artery before any resection. The feeding vessel originates from the aorta and carries blood at high systemic pressure. If accidentally transected without secure ligation first, massive arterial hemorrhage begins immediately, and the distal stump can retract into the mediastinum or below the diaphragm, making it extremely difficult to find and control. This is precisely why computed tomography angiography must be performed before every resection to map every feeding vessel in detail. The principle is simple but life-saving. Find it first, ligate it securely, and resect. Case 13. Chest radiography. An adolescent patient is investigated for a persistent chronic cough. Chest X-ray reveals a mass in the posterobasal segment of the left lower lobe with cystic spaces and air fluid levels visible within it. The question is, what is the most likely diagnosis based on these radiological findings? Option A. A primary lung abscess from community-acquired pneumonia. Option B. A pulmonary hydatid cyst with rupture into the bronchial tree. Option C. An infected intralobar sequestration in its classic location with characteristic post-infection cystic change. Option D. A cavitating tuberculosis lesion in the lower lobe. Focus on both the anatomical location and the radiological evolution described in the case. The correct answer is option C. An infected intralobar sequestration. The posterobasal segment of the left lower lobe is the single most classic location for bronchopulmonary sequestration, accounting for over 90% of all cases. Before infection, the lesion appears as a solid homogeneous mass. After bacteria gain entry through collateral channels, infection creates cavities. These cavities fill partially with pus and partially with air, producing the characteristic cystic spaces with air fluid levels on the chest X-ray. Any persistent or recurrently infected lower lobe mass in an adolescent, especially left-sided and posterior, should prompt immediate computed tomography angiography to look for the systemic feeder vessel. Case 14. Uncommon presentations. A 16-year-old previously healthy female presents to the emergency department with sudden onset hemoptysis, meaning she is coughing up blood. Computed tomography confirms an intralobar sequestration. The question is, what is the most likely mechanism explaining the sudden onset hemoptysis in this patient? Option A. Spontaneous pneumothorax causing tearing of pleural vessels adjacent to the sequestration. Option B. erosion of the high-pressure anomalous systemic artery into the bronchial tree caused by chronic infection and inflammation. Option C, rupture of an esophageal varix due to portal hypertension from hepatic involvement. Option D, pulmonary embolism causing hemorrhagic infarction within the sequestration. Think about what repeated cycles of infection due to the tissue surrounding a high-pressure arterial vessel over years. The correct answer is option B, erosion of the high-pressure anomalous systemic artery into the bronchial tree. The aberrant feeding arteries carry blood at high systemic pressures and are surrounded by tissue progressively damaged by recurrent infection. With each episode, chronic inflammation and architectural distortion gradually weaken the vessel wall and its surroundings. Over time, this causes the high-pressure arterial wall to erode directly into the adjacent bronchial tree. When the vessel breaches the airway wall, the patient experiences sudden, potentially massive hemoptysis. This is a surgical emergency and one of the strongest arguments for elective resection before this complication ever arises. Before our final conclusion, I want to tell you about our exclusive pediatric case review community on Patreon. In this community, all of our videos are neatly arranged by organ system, so you can go directly to the topic you need without searching through your feed. All the presentation slides used in each video are also available as high-quality photos, so you can read through them, review the cases, and practice all the board-style questions at your own pace. If you are interested in joining, simply comment below this post, and we will message you directly with all the details on how to subscribe. And that brings us to the end of today's lecture on bronchopulmonary sequestration. Let us consolidate the key takeaways. Bronchopulmonary sequestration is a mass of non-functioning lung tissue with no tracheobronchial communication that receives blood from an anomalous systemic artery arising from the aorta. Intralobar sequestration accounts for 75% of cases, shares the visceral pleura, presents in older children with recurrent same-location pneumonias, and drains into the pulmonary veins. Extralobar sequestration has its own separate pleural envelope, presents prenatally or in the neonatal period, is strongly associated with congenital diaphragmatic hernia, and drains into the systemic venous system, which can cause high-output heart failure in large lesions. Computed tomography angiography is the gold standard, and secure ligation of the systemic feeder before resection is the most critical surgical step. Please follow our channel for more high-quality pediatric case reviews, and drop any questions in the comments below. Thank you for watching.